Welcome, everyone, and thank you for your patience as we are getting started here. We're just going to give a chance for people to enter the room. Great. So given that we have a group together, I'm going to get us started for tonight by saying welcome and thank you for joining us, and happy World Psoriasis Day to everyone. We're very glad that you could spend some of your evening with us tonight. My name is Antonella, and I'm the CEO of Psoriasis Canada, for those of you I don't know yet. And before I begin, I want to acknowledge that I'm located in Toronto, the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and now home to many diverse First Nations, Inuit, and Métis people. We welcome everyone who's joining us from wherever you are today. So before we get started on the event tonight and introducing our amazing speaker that I'm very much looking forward to, just want to go over some brief housekeeping. You may already be very savvy with Zoom, but just a reminder that to listen in French tonight, you can select the interpretation button at the bottom of the screen to toggle to select listening to this presentation in French. And you will have been informed that the webinar is being recorded in English and French so that it can be posted for viewing shortly after tonight's event on our YouTube channel at Psoriasis Can 1. All participants will be in listen-only mode because we're recording. So for the duration of the session, if you have any questions, please do enter them into the chat box or Q&A box, and we will do our best to get to all of our questions at the end of the session tonight. And with all of our webinars and resources, we always remind people that the information in the presentation is general information. So any personal or specific questions and concerns that you may have, including any risks and benefits of your care or treatment for your situation, we always encourage you to be informed and to talk to your doctor. And I want to share a heartfelt thank you to our World Psoriasis Day supporters on the screen here: AbbVie, Arcutis, J&J, Eli Lilly, Sun Pharma, and UCB, who make these events possible. We're grateful for these sessions. So for those of you who don't know us yet, I just want to briefly introduce Psoriasis Canada. So we are a relatively new organization that was a consolidation of two psoriasis groups, the Canadian Psoriasis Network and the Canadian Association of Psoriasis Patients. So in 2024, we came together to form one strong voice for psoriatic disease in Canada. So while Psoriasis Canada is new, it's built on more than 15 years of experience and knowledge. And we've actually just released our first strategic plan. So I invite you, if you haven't checked us out yet, please do. Again, we're on all social channels at Psoriasis Can 1. And I'll provide more information of how you can stay in touch as well. So what brings us here today is that it's World Psoriasis Day, and it's an opportunity for us to come together to raise awareness about psoriatic disease. And this year's theme is about comorbidities, which just means the health conditions that can be associated with psoriasis, in that people with psoriasis may be at higher risk of experiencing these conditions than the general population because of the nature of psoriatic disease. So as part of our World Psoriasis Day activities this year, we've launched an educational social media campaign highlighting the associated conditions that are common with psoriasis. And we've learned from our community via a survey we did this summer on some of the key points of interest from our community. So we've developed a series of webinars, including tonight's, that speak to some of the main concerns that we heard through talking to or through surveying our community. So thanks to all of you who may have filled that out and contributed to the content for our World Psoriasis Day activities this year. So again, when we talk about associated conditions, we know psoriatic disease is not just a skin condition. It can be associated with conditions that can complicate psoriasis and treatment and worsen a person's health outcomes. And despite this, what we learned is that awareness of these comorbidities can remain low among patients and even healthcare providers. And this gap in knowledge can lead to delayed screening and prevention efforts, and then potentially inadequate management of psoriasis and associated conditions. And in fact, in the survey I mentioned, 73% of the over 300 people who responded said they don't feel well informed or feel somewhat informed only about the health risks linked to psoriatic disease, including mental health, which we're talking about tonight. So we hope through this session and the others that I'll mention on the next slide is by equipping people with psoriasis, healthcare providers, and the public with this information, we can foster understanding about associated conditions and raise awareness so that people can, bring things up if they have any concerns with their doctors. And with that, I want to let you know, if you haven't signed up for these other sessions, that the webinar that we did on psoriatic arthritis is now posted on our YouTube channel, again in both English and French. And the next session, which will be on cardiovascular disease and psoriasis, is taking place on November 6th. So if you haven't registered yet, the QR code is up on the screen. And again, you can get links to our social media channels to register for that. So I'll keep that up for a second so that people can use the QR code if they'd like. And in addition to these sessions, because we're talking about mental health tonight, we also wanted to make sure that you're all aware of an online support group program that we're running. So our next session is November 19th at 7 p.m. Eastern time. Again, the QR code is up on the screen if you want to check out the registration for this. And essentially, it is a peer facilitated group discussion where people with psoriatic disease can connect, chat, and share experiences together. So far, we've been hosting these in English, but we are planning to have more sessions and sessions in French in the future. So if you want more information about future sessions and you're not already in touch with us, we invite you to please keep in touch. Again, you can follow us on all major channels at Psoriasis Can 1. Our email address is on the screen, and our website is www.psoriasiscanada.ca. So with that, I'll stop sharing my screen, and I'll turn it over to the topic du jour. So the mind-skin connection, especially as it relates to psoriasis, is a topic that comes up a lot from our community. And in 2022, we conducted a psoriatic disease community survey, which included over 500 participants who live with psoriasis and/or psoriatic arthritis. And what we heard from that survey was that 63% of participants said the disease made their quality of life worse. 51% said psoriasis changed how they go about their day-to-day life. 48% shared that they have less confidence in themselves because of their condition. 47% report struggling with sleep. 40% said that their condition negatively impacted their romantic life. And 26% said they don't like going out with friends because of their condition. They also told us that they wanted to reduce pain. So 69% of people shared that. 64% said they wanted to reduce anxiety, and 59% said they wanted to reduce sleep disturbances. So this is a very important topic for our community. And given that psoriasis can impact all areas of life, we really wanted to ensure that we talked about this as mental health conditions are very common associated conditions with psoriasis. And we wanted to learn from an expert who's doing amazing work in Canada to advance our understanding of the relationship between mental health and psoriasis. And it's my pleasure to turn it over now to our speaker of the evening, Dr. Marlene Dytoc. I heard Dr. Dytoc being interviewed on the JCMS Dermatology podcast. I was fascinated by the work that you're doing, and we were grateful that she was available to be with us tonight. So we encourage everyone to ask questions. Again, we're going to have a Q&A session after the presentation by Dr. Dytoc. And Dr. Dytoc will also encourage you to share input to inform some of the work that she's doing that she's going to share with you tonight. And there will also be an opportunity for you to share input on mental health and your experiences in the evaluation form that we're going to be sending around after the event. So we hope that this will be a little bit interactive. And with that, I'm very excited to turn it over to you, Dr. Dytoc. I have a brief bio as I also pull up the slides here. Just give me 1 second.
I'll share screen if you don't
Oh,
mind.
you're sharing the
Thank
screen. That's
you.
right. Okay, thank you.
Thanks so much.
So I welcome you then to pull up your slide deck while I introduce you. Dr. Marlene Dytoc is a clinical professor of medicine in the Division of Dermatology at the University of Alberta. She also serves as the Deputy Edmonton Zone Chief for Dermatology, the Undergraduate Medical Education Director for Dermatology, and the Divisional Lead for Quality Improvement at the University of Alberta, the Provincial Lead for Dermatology in Connect Care, and in the Competence Committee and Residency Program Committees for Dermatology at the University of Alberta. She's a graduate of the Medical Technology Program in Rochester, New York, USA, and she pursued studies in microbiology and immunology there and was awarded her Doctor of Philosophy degree at the University of Toronto in Canada. She earned her medical degree at the University of Toronto and completed her dermatology residency at the University of Alberta. She's certified as a fellow of the Royal College of Physicians of Canada and a member of the Canadian Dermatology Association. And her special clinic and research interests include psychodermatology, which we're going to hear a lot about tonight, atopic dermatitis, and occupational hand eczema, as well as vulvar dermatology, in addition to general dermatology at the K. Edmonton Clinic and the University of Alberta. So with that, thank you so much for being here. I'm really excited to learn from you tonight, and I turn it over to you, Dr. Dytoc.
Hey, thank you so much, Antonella, and also to Helen for inviting me, and to all of you for coming out tonight in your time zone. I'm in China, teaching on behalf of the U of A, University of Alberta. So I would like to share with you one of our strong pursuits, which is the brain-skin connection, specifically how mental health and skin conditions, notably psoriasis, are related and how we can help our patients better. The objectives for this presentation is number one, to address why we need psychodermatology. And you as patients probably live with this and know more. We made a little case control study to uncover and highlight the psychiatric comorbidities in psoriasis. And then knowing that need and that gap in care, we have devoted our research into many aspects of psychodermatology, one of which is the development of a practical tool to screen for the psychosocial impact of psoriasis and other skin conditions. So we will highlight in a short amount of time our endeavors towards the validation of the Mind Skin Health Index. This is similar to DLQI, or Dermatology Quality Life Index, in the sense that it's a questionnaire that can be administered to patients alongside a care pathway. However, it is not DLQI, and you will see that in a moment. And of course, we want to promote that there is a care pathway that we can offer patients through their healthcare provider or to patients directly to address the psychosocial impact of psoriasis. I will start with small case, but very significant, very important. Then we will go back to this case. Okay. So a 37-year-old female with long-standing psoriasis comes to our office tearful throughout her visit. She reports feeling down and depressed. She is on a combination of antifungal and steroid cream, and she's also on antidepressant called sertraline. So previously sorry, I'm losing my arrow here. Previously, we would, if we had the time as a general dermatologist, pull out the criteria for depression. And later on, I would submit to you what we do. So there's, you know, a questionnaire that one can use for depression, but it's just for depression, and it does not ask about anxiety and so on. Plus, it takes time to go over this with a patient. So I'm just going to backtrack a little bit and talk about psychodermatologic conditions. So psychodermatologic conditions include psychophysiologic disorders, and that's when skin disorders are worsened by emotional stress, such as psoriasis, for example. And then there's also secondary psychiatric disorder, which are skin disorders such as psoriasis that can result in depression, anxiety, social phobia. So how common is this? We did a survey of 78 dermatologists through the auspices of the Canadian Dermatology Association. And they said that frequently, which is the gray, and very frequently, which is the yellow here, they do encounter secondary psychodermatological conditions. And then we asked, what is the percentage of patients with psychodermatological conditions in their practice? And again, we have here the orange of 10 to 25%, and then at least less than 10% in the blue. So quite a number. And then we asked, what is the best approach to psychodermatology in your area? And if I were to have my cake, I would say, of course, multidisciplinary approach when we have both the psychiatrist, psychologist, and the dermatologist in the clinic. But such is not the case. There's very few psychodermatology clinics in Canada. I can count 3 across Canada. And one is ours, it's called Skin Health Canada to avoid stigmatization. So, what is the next best thing? Well, dermatologists can refer to psychiatry and talk to them about the conditions. However, a lot of patients decline referral to psychiatry. So here in the gray is often, and in the yellow, most cases. So then we realized more than ever that we need more research into addressing this gap, more patient resources, and more training for the healthcare providers, for our residents, and medical students. So we've been doing that in the last at least 5 years. So in our skin health clinic, we deal with psychophysiologic disorders and secondary psychiatric disorders in psoriasis patients. I mentioned briefly that we did a case control study to see what are the statistically significant psychologic comorbidities in psoriasis. Are there depression, sleep-wake disorders, and so on that are associated with various skin conditions? And this is through a all of us database of 500,000 patients. So here, if I may just draw your attention to the statistically significant associations of these conditions with psoriasis, we start with sleep-wake disorders. So inability to sleep or too much sleeping, for example, depression, post-traumatic stress disorders, personality disorders, obsessive compulsive disorders, anxiety disorders, somatoform, and that's when a patient is focusing so much on their condition of the skin, bipolar, and then other things such as schizophrenia, eating disorders, substance use, and neurodevelopmental and neurocognitive disorders are significantly associated in patients with psoriasis. Way back, we also looked at what is the most frequently prescribed psychoactive medication to patients with dermatologic conditions in Alberta between 2014 and 2018? And we found that the most frequently prescribed psychoactive medication are antidepressants. So here, if we look again at psoriasis, right here, we see that the most frequent one is antidepressants, and then the green one is anxiolytics. And then the orange, we also have hypnotics, and then to a less extent, anti-epileptics and antipsychotics. But by and large, antidepressants and anxiolytics. So what did we do in the past with patients? If you had the time in the clinic, you would bring out the PHQ-9. And the PHQ-9 actually is a questionnaire for depression. And before that, we can offer the PHQ-2, which is 2 questions about depression before you launch into PHQ-9. However, it doesn't deal with anxiety. There is the hospital anxiety and depression scale that one can use. And then the patients would have to, again, answer this questionnaire, but it deals with anxiety and depression and not so much quality of life. So now we have 3 questionnaires, including the DLQI or the quality of life. Okay. When we looked at the patients in our skin health clinic to see if they improve over time in PHQ-9, DLQI, and had scoring for depression and anxiety, there is a trend to improvement. But you know what? A lot of times the patients leave this incompletely filled out because there's so much to ask a patient to do this and that questionnaire, and it also takes time. So we thought, okay, we're gonna create a Mind Skin Health Index, a questionnaire that's more comprehensive. That's just one questionnaire that the patients hopefully can fill out that will lead us to take care of the psychosocial impact, address this better. So this MC deals with questionnaires that pick up secondary psychodermatologic conditions like anxiety, depression, even suicidal ideation, and also primary psychodermatologic conditions like skin picking, hair pulling, delusional infestations. And the hope is to guide clinicians to appropriate referral or further psychological evaluation and to foster interdisciplinary care. So first, we did a systematic review of the tools out there that's being used for psychodermatology. We found that they're fragmented and few tools address both psychosocial impact as well as primary psychodermatologic disorders. There's high variability. And so we found that we need something that's integrative, comprehensive, and with high clinical usability. So after the systematic review, we did evidence mapping of the quality of life instruments. We looked at the DSM-5 criteria for different psychological comorbidities that we found in our case control studies. And we found 19 key items or domains that we need to address in our questionnaire. So I'm going through this a little bit faster because I just want you to capture the essence as opposed to all the scientific process that we had to go through to get to the questionnaire. We also validated this with experts, dermatology, psychiatry, psychology, primary care, rounds of consensus and feedback, and then also with patients because we want this to be patient-centered. In the end, we'd have 18 items, which takes about 5 minutes to complete. Plus, we also have prompts for clinician follow-up when it comes to suicidal ideation. So this is how it looks like. And there's a care pathway to see if the suicidal ideation is imminent, moderate, or low risk, and what to do about it. So in Alberta, we have the Skin Health or Psych Derm Clinic, both in Calgary, one under Dr. Kirk Barber, who is old as I am, my greatest mentor. And then also in Edmonton, we have a psychiatrist in our clinic, or in Calgary, it's asynchronous. We have access 24/7, and that's covered by Alberta Health. Patients directly can contact 780-424-2424 and get matched with a psychiatrist and or a psychologist. And at the very least, we can pick up the phone or write to the family doctors, depending on the acuity. So we're in the second phase of validating to look at specificity, sensitivities, cutoff scores, again, with patients as our guide. So in psychodermatology, at this point, in summary, it's not, of course, only the questionnaire that we need to do, but I think that that is a start because dermatology clinic is very fast. We're all very busy, and we hope that this questionnaire can be administered to the patient. The dermatologist can see another patient and come back and then look at the scores and then go through the care pathway. So in psychodermatology, of course, we need to build a trustful therapeutic relationship. We need to talk about what their conditions are, not just the skin, but also the psychosocial impact. If we have any need for psychotropic medication, I feel that this is a bridge to addressing the stresses in our life and trying to cope, having some coping mechanisms and skills. So that's in the way of cognitive behavioral therapy and mind body techniques. We did another study, I will not show this, that in atopic dermatitis, for example, the evidence shows that online CBT is as good as in person. And so there's certainly a role for therapy and mind body techniques like music therapy, progressive muscle relaxation, if one is scratching, habit reversal therapy. Of course, let us not forget skin-directed therapies, very important, right? Because if our skin is better, then hopefully that's a way to have our psychosocial impact better as well. There is such a thing as psycholag, meaning that even though the skin is 100% better, PASI 0, that's psoriasis area severity index, there is psycholag, meaning that depression, anxiety does lag behind and takes time to improve. So sometimes the psoriasis may be milder, moderate, but if there's significant psychosocial impact, I think that as clinicians, it behooves us to be more assertive in our therapies to clear the psoriasis. So just a little word on psoriasis and race. African Americans are reported to have higher average BSA or body surface area at baseline compared to white patients. And that's 3 to 10% versus 1 to 2%. Indigenous Canadian patients have an increased rate and severity of psoriasis compared to other ethnic groups. Hispanic, Asian, and African American patients are more likely to present with 20% BSA involvement than white patients. And the severity of psoriasis in brown Black patients may actually be underestimated because PASI, the scoring that we do for psoriasis severity, heavily relies on erythema, which in skin of color is not erythematous, pink or red, is actually brown or hyperpigmented. All right, so again, I want to highlight that besides treating the patients with psychotropic antidepressants and anxiolytic, it's very important, I think, to have therapy and mind-body techniques, again, to allow us to better cope with our psychosocial stressors. However, in the studies that we reviewed, there's still a need for high quality randomized controlled trials to make a definitive claims. If one is itchy, psoriasis can be itchy. For example, There is habit reversal therapy. So this has the most evidence. For example, clenching the fist, holding it still for 30 seconds, pinching or pressing on the area that's itching until it doesn't itch anymore, and doing that several times a day. Of course, this one is studied more in atopic dermatitis, where are cognizant that psoriasis can also be itchy. And in children, we actually do not advise the child to stop scratching. Instead, we distract them and intervene in a positive and helpful manner. So this is just an example of a mind-body technique that one can use. Also, we have started to develop, and we actually are now doing a randomized control trial of the videos that we created. It's called Mind Skin Health Videos for Atopic Dermatitis. And this is born from scoping review and environmental scan of what are the content of patient educational tools that address psychosocial impact in atopic dermatitis. And we want to have another project um, following this model for psoriasis patients for you. And so in the feedback session, we'd like to know about what are the content, what are the topics you would like in your videos. For example, for this one, for MSHAD, Mind Skin Health for Atopic Dermatitis, we have some welcome to the wellness journey. So you can think about this as psoriasis wellness journey, exploring the skin-mind connection. And we have one for adults and one for children, breaking the itch scratch cycle. Then we put in some tools for self-management skills, how to build a support network, and then holistic skincare and wellness. So if you're interested, please let us know so that we can start developing this for you as well, and what content you would like. We're also big on support groups. I am very pleased to hear that you do have a support group for psoriasis. Um, Ours are more expert-led. For example, we have one for vulvar dermatology, lichen sclerosis, and expert-led means, for example, for vulvar dermatology, we have the gynecologist and myself, dermatologist, or for excoriation disorders, we'd have the psychiatrist and myself. For this particular support group for lichen sclerosis, which is a vulvar conditions, we actually found that from the first month, after the first session, second and third session, there is significant reduction in this quality of life index for vulvar patients, and it's statistically significant. So we're enthused, and I'm happy to note that you also have your own Psoriasis Canada, and we can certainly participate in that if you would like. We are also developing the Mind Skin Health Canada website so that more people are aware of the work and the opportunities that we have to address this very important comorbidity of psoriasis. And we as practitioners, dermatologists, and psychiatrists, we also meet regularly to learn from each other, support each other, discuss our challenging cases. So going back to our case, today we are working on further validating the Mind Skin Health Index, and hopefully we can screen in a efficient manner the psychosocial impact of psoriasis in our clinics and having the care pathway to deal with it. We are also poised to develop more educational tools for our psoriasis patients, addressing the psychosocial impact of psoriasis, and then also to be in touch with support groups that are expert-led, that we can help further. Clinic time is very short, and we found that the Q&A sessions during the support groups are very satisfying to the patients, if I may say so. And also the Mind Skin Health Canada group and website are working together to further address the psychosocial impact of psoriasis and other skin condition, and hopefully this patient that we have in our case, which is not uncommon, will have better care. So I open it now to questions. And again, I thank you for your kind attention.
Thank you so much, Dr. Dytoc. And we're very happy to have you here, as I said, and very glad to know that you're doing this work and that you're advancing expert knowledge in the mental health and in this case psoriasis, and that you're engaging with patient organizations like ours to actually hear from the patient community and see how we can work together to support people who may be experiencing some of the challenges you've talked about. So thank you very much. I hope this is the first of many conversations to continue having together. There are some questions that I will turn over to you. One is, thank you to this space dedicated to psoriasis awareness. My question, what does the latest research suggest about the potential role of mindfulness in dealing with psoriasis?
I'm glad. Thank you very much for your enthusiasm, and I really appreciate the feedback, because sometimes it can be a lonely road dealing with psychosocial impacts of skin disorders. So I'm enthused, and certainly we do offer mindfulness sessions as well. In Alberta, there are some online, and that you don't have to pay for. This is you know, under the auspices of psychiatry. So I'm very glad that we have collaboration with psychiatry, not only in research, but in our clinic. Again, the RCTs, or randomized controlled trials, are still lacking, but I do believe that mindfulness is very important as, psychotherapy and mind-body technique for dealing with the psychosocial stressors in skin conditions such as psoriasis.
Is there a lot of research looking at some of these like psychosocial interventions and things like psoriasis, or is this something that isn't looked at academically very often? I know it's a lonely
Yeah.
road.
So it's more case reports and case series. So it's not powered to let us know if really it's working or not. Um, One has to also think about funding. When we do studies like this, somebody has to pay for the mindfulness session. It's very difficult to get the funding to do this, and to do this in a long-term fashion, because certainly one mindfulness session is not going to do it. So we're hoping that with more promotion that we can actually do these RCTs. There are systematic reviews that are published, and again, there's a dearth of controlled studies.
Absolutely, and we do know about the impact on stress. We have research on that, I suppose, in terms of mindfulness practices. So that's great. And another, I'm just going in order here because there was a few, but is the Mind Skin Canada website available yet? And if so, is it possible for us to put the link in the chat?
Yeah, so we're not live yet.
Okay.
We have a volunteer, actually, the son of Dr. Barber, who's doing this website with us. But as soon as we'll give it to you through Psoriasis Canada, and I'm very happy that you're interested.
Super. And as soon as our new website launches, we'll hopefully have a space that's just dedicated to mental health, and we will certainly pop that link in there and support each other how we can, right? Um, so another question here is, I have had lichen sclerosis many years. I got psoriasis 1.5 years ago. Are they related? Can you speak to that at all?
There's many things that we still don't know about skin conditions. Certainly, the pathophysiology of lichen sclerosis and psoriasis are not linked. We think that lichen sclerosis, though, is familiar, and so is psoriasis. So it's interesting that one day maybe there will be a more defined link. Mm-hmm.
Okay, thank you so much. And speaking of links, I do have a question here about, um, could you explain the connection between mental health conditions, specifically depression, which you talked about as being like more correlated to psoriasis? Um, the link between depression and psoriasis, specifically the biological or psychological mechanisms that are happening that connects the two. Like, can you speak? Like, we do hear about stress, um, impacting flares, for example, and we know that there is that relationship between psoriasis and depression. Can you speak to a little bit about the mechanism behind what's happening there?
For sure, a lot of it is not known. However, we have looked at certain immunologic signatures for psoriasis and depression, for example, and tumor necrosis factor alpha is one of those immunologic mechanisms involved in both depression and psoriasis, although we have better biologics now than the TNF blockers to deal with psoriasis. So that's a common pathway there. And we hope that we can define better the immunologic signatures for both. And that's actually one of my project proposals that are begging for funding, because now you can't just do an ELISA immunoassay. You have to do genomics, you have to do transcriptomes, which, is a bigger deal when it comes to funding. And so we want to know what the common pathways are for psoriasis and the mental health conditions like depression, and then how our biologics are targeting this. So hopefully we can do and know more.
Okay, amazing. And because we were talking about depression, I'm going to pop in some resources in the chat because you talked about some great um, resources in Alberta. There are some Canadian helplines. Just putting it in the chat as a resource for people to take down in case it's ever something people need, because they may not know about that. So another question is, thank you, Dr. Dytoc, for the insightful presentation. Wondering from your perspective, aside from dermatologists, how can pharmacists better support psoriasis patients with mental health?
I think that's a very important avenue of help, because pharmacists, they do counsel patients as well, and they might be able to see that patients are on psychotropic medications and also have psoriasis medication, are being treated for psoriasis. And there's certainly a lot of overlap. And as I mentioned in the talk, I consider psychotropic medications are a bridge. And therapy, mind body techniques, it just makes sense, right? I'm having some more skills, mechanisms to address psychosocial stressors is more, I feel, more sustainable. So certainly the pharmacist can make the patients aware to address this. If not a psychodermatologist, or then the family doctor. And that's why we're working to validate further our tool, the Mind Skin Health Index, for example, so that it'll be commonplace for healthcare providers to identify these patients who need more help. Mm.
Okay, that's very, very helpful. Thank you. Someone commented that they find the work that you're doing interesting, especially with anxiety, and that maybe more needs to be done with social workers in terms of skin conditions and anxiety. So yet another allied health professional that's getting mentioned in the comments for how we can all kind of be attentive to this and support each other where possible. Do you have social workers involved in the clinic or in any of the work you're doing?
No, and I thank you very much for that suggestion that we should also involve social workers in our stakeholders. Um, you know, we try to involve as many people. We have another project in the indigenous population, and we are cognizant that we have to involve the elders as well. And so we're learning that we can expand our stakeholders for the project. So thank you very much for that suggestion.
Fantastic. And thank you. These are amazing questions, and they're different. They're coming from different perceptions. So I appreciate you answering them all. The next question is, again, a different, going a different route. Is there a link between psoriasis and the use of lithium?
Yeah. So actually, I just taught this yesterday here in China when I was teaching medical students on psoriasis. We have a whole case, several days devoted on psoriasis. And so certain medications like beta blockers things like atenolol, things that start with LOL, and that's not laugh out loud. That's a treatment for hypertension or high blood pressure. Lithium has been associated with exacerbation of psoriasis. And then you think, well, then is it just enough to change the medication, or should we address the psychosocial impact beyond a medication change?
Thank you so much. And someone also shared, thank you for sharing how to help children with itch. Their daughter has the most trouble at night when distraction isn't an option. And again, this isn't personal support for a personal case, but are there any general recommendations for night itching in children, given that
Mhm.
distracted
So
them?
when we prepare our residents in dermatology for their Royal College exam, we always say, start with general measures. So, pH 5.5. So how would we know it's 5.5? Hypoallergenic cleansers. So we do have some recommendations as well when patients come to our clinic and samples. So the pH has to be around 5.5 for the cleansers and also hypoallergenic so that you don't strip the skin barrier and then you lend yourself more permeable to allergens and irritants. And also there's more transepidermal water loss or more dryness, and dryness drives the itch. So hypoallergenic moisturizers as well, emollients. So now people are coming with all these itch relief creams, if I may say so, like Aveeno, Eucerin, CeraVe. They have special ingredients. We call them therapeutic moisturizers that help with the itch as well. Um, and then there's also certain medications, topical, systemic, that actually help more with the cytokines that are involved in itch. We call them pruritogens. And then in terms of a young child, in the old days, and this has been published, sedating antihistamines work better, not so much because it's an allergic reaction and you're having this so-called IgE mediated immunologic mechanism, the way you would do when you eat peanuts and you're allergic and you have an anaphylactic reaction. But the antihistamines at night, they work because they're sedating. So they make you sleepy, you forget to scratch. But the flip side of that is that the longer acting antihistamines that are sedating, like hydroxyzine, they also have sort of like a hangover effect that may affect concentration in during the day when they're in school, for example. So I submit to you that it's a package of trying to optimize the general measures, the medications that you're using for psoriasis, or I'm not sure if your child has eczema and not psoriasis. And that goes along with like the topical therapies and the systemic therapies as well, so that hopefully that can be alleviated, that itch. We go through many things, including wet wrap therapies and so on. So there are certainly things that we can do.
Thank you so much, Dr. Dytoc, for that great answer and thorough answer. Again, we're shifting gears slightly back to Mind Skin Canada. There's a couple of questions about some of the work that you're doing here. One is your MSH index specific to psoriasis, or can it be an index for any skin disease?
Yes, for any skin disease. So what we're hoping to pick out is the psychosocial impact of skin diseases. I also see question, if I may, about the Mind Skin Canada, a website. So when that is up, then certainly we will have an avenue for other healthcare professionals to join in, because we certainly would like the support and the insight as well from other healthcare providers.
That actually leads to the next question that's in the chat. Will Mind Skin Canada provide educational opportunities like webinars specifically for health professionals? Do you see that as something?
Yes, absolutely. So we're putting our videos, etc., there, and then it will go live. We're putting all the tools that were born out of our research, and then also to invite other people to contribute. Yeah.
Okay. And then again, going back to questions about treatment in this case, do you have any thoughts on the role biologics are able to play in treating this condition? So probably this condition being
Yeah.
mental health conditions. Yeah.
Yeah, and that's something very exciting. And I said we're on the lookout for funding, to look at immunologic common signatures for both psoriasis and, say, depression, anxiety, and other psychosocial more comorbidities of psoriasis. And I mentioned, for example, the TNF blockers. TNF alpha, tumor necrosis factor alpha, seems to be a common mechanism for depression as well as for psoriasis. However, there are better biologics giving you an improvement in PASI more than TNF blockers. But we want to uncover more of those immunologic signatures. Yeah.
Okay, fantastic. Thank you. So the last question I'll ask before we let you go, because I know you have literally a plane to catch, is do you have any advice for people who might be struggling with depression, anxiety related to their psoriasis, and how to approach that with their healthcare professional and in particular, their dermatologist, who they're probably is the only provider they're seeing?
hmm I think it's important to mention it to the dermatologist and or the family physicians as well. Psychotherapies, mind-body techniques, psychotropic medication, they're not new. But I think that's why we started on the MSHI, the Mind Skin Health Index, because I think most of the gap is in actually picking it up, in recognizing, in detecting it that people need help, and that's why we focus on this one first. Um, and hopefully then it will be commonplace for dermatologists and other healthcare providers dealing with psoriasis to give this questionnaire to detect that, because a lot of times the patient is opening up to you and you just don't have the time. And I think that we need to be empathetic and efficient as well. And that was one of our earlier projects as well as, trying to be empathetic as well as efficient. And that's with Eli Lilly Canada in healthcare providers. So definitely we have more to do in this aspect.
We're really grateful that you're doing it and that this conversation is happening, and we're thankful to you for being a leader in this. And actually, the last comment isn't a question; it's a comment saying um, to thank you for all your work with psoriasis and mental health. It's unbelievably helpful. So I hope that gives you more gumption to keep going, even though I know it's not easy. And I was really excited to hear, again, like I said, hear your talk on and your interview, so that we could start talking about this together as a community. And some of you may have missed it. Dr. Dytoc is actually teaching in China right now, so we are going to keep to our word and make sure that she's out of here by 8 o'clock to catch her flight home. Um, and it just goes to show your commitment to what you're doing and to this work. So thank you. We've put our evaluation form in the chat, so we ask everybody to please take a second to fill it out. It helps us do a better job in all of our events to understand what you need. And in this case, it's a special opportunity to share feedback to Dr. Dytoc about what some of the resources would be helpful, or topics that would be helpful for some of the modules that she described in terms of mental health and psoriasis. Do you want to mention anything else about that, Dr. Dytoc, in terms of those questions?
Yeah, again, I thank you so much for the opportunity. And we were going to take this back to our team as well. And yeah, if you have any feedback, suggestions on the content of the Mind Skin Health educational tools, um, it's in the format of videos, but if you have other formats you can think of, sure. And we want to develop this for psoriasis. Yeah.
Perfect. Thank you again so much. And thanks to everyone. The evaluation form will go around post event. You can rewatch this again on our YouTube channel in the next few days. It'll be posted there. Dr. Dytoc, thank you again so much for your time, expertise, and work. And we look forward to working with you more on this important topic, and wish you a very safe and smooth travel home.
Thank you so much.
Great. And thanks to
Bye.
everyone. And I have to say this, go Jays go if you're watching. We're also letting everyone off in time for the game. Take care, everyone. Bye.